So you know me, Dusty Otwell, Vice President of Risk and Claims for U.S. Acute Care Solutions, malpractice lawyer guy. This is John Bedolla. John Bedolla is the National Director of Risk for U.S. Acute Care Solutions. He's the medical review for all of my malpractice cases. He also takes everything we learn in malpractice cases and tries to put them into effective tools, programs for our company. But that's not all you do. What else do you do? Tell them about yourself.
I am also one of the Formula One certified doctor, and do research in the area of rare and catastrophic events. And I've helped write a chapter on terrorism for medical infrastructure of terrorist organizations. And I, like you, like following the suicide lecture because I'm not a particularly witty person, but after a suicide lecture, I look pretty good.
You're hilarious.
I can get a few laughs after that.
Yeah,
so.
Right.
Anyway, so.
But UT Medical School.
Oh yeah, that's right.
Professor.
Yeah. I teach at the medical school. Yes, also.
So we're going to talk till, I'm going to keep my eye on the clock. We're going to talk till about 5:15. This is kind of a question and answer. We have our own questions, the 10 most important legal questions. All these basic malpractice risk questions that we're going to run through and talk about. But I encourage your questions as well. And if we get some, I'm going to call on you. I'm going to repeat your question. If we start getting too much into a rabbit hole, we're going to keep going. And then we're going to go till about 5:15, keep my eye on the clock, and then we'll ask one more question, then we'll be done for the day. So let's crank it up.
Roger that.
So we'll start with consent. We get a lot of questions about, hey, should we be getting consent for this, for that? So a couple of examples. You got a carpenter partially severs his index fingertip with a saw, requires a distal digit amputation repair. Would you get a separate written consent here, John?
Well, if you don't do a procedure very rarely and you think there may be a complication, you definitely want to at least write it. Write a thorough note and that you explain the risks and benefits. And I would say that especially if you're going to replant the distal digit, then you definitely want to get a consent. If you're just going to sew it and close it, then just document why you're sewing it and closing it or leaving it open. But procedures that you perform rarely, it's better to be more heavy on the consent end.
Yeah, I like that point. What about if you've got an abscess on the face requires IND? Separate written consent?
You don't really need to, but here, of course, it's a female and an abscess on her face, so you want to document a little bit more. The main thing to explain, of course, is that anytime you cut on the skin, there's going to be a scarring.
Yeah,
and there's no way to avoid that.
And to your point, when we get these questions about a separate written consent, I'm talking about some separate form that we're going to have the patient sign, as opposed to just documenting it in the medical record. And usually, I try to reframe the conversation to, well, tell me about your medical record documentation in these cases. Maybe we want to add a written consent to it, but I'm really more interested in the documentation in the medical record about the risk, benefits, alternatives, rather than just the written consent. Now, usually the question comes about a CT. Should we be getting a separate CT consent? Do you get a separate written consent for CT in the places you work?
No, definitely not. No, and if say they're pregnant, then I would document the risks and benefits. And essentially what you have to do, generally speaking, with consents, and this includes the consent to discharge someone home, which is a consent conversation. I say that the risk of doing what you recommend they do is actually less than the option. So if you recommend a pregnant lady get a CT, you just need to document it in your own mind, feel like the risk of not doing the CT is greater than the risk of doing the CT.
Yeah, and it kind of returning to my general point of, I'm really looking for the documentation. Because when it comes to consent, when they come in, they sign a bunch of stuff. Most of the stuff you're doing for these people has already been kind of squared away in the documentation they signed when they came in. So if something goes bad, I really want to see documentation about, discuss with them the risk, benefits, and alternatives of CT, this abscess, the finger thing. And that is really going to help me create a narrative of they talked about it, the patient was well apprised, and things went south, but it's not their fault. Yeah, we have a question here. Yeah.
Yes.
That's a great question. So the question is, we're talking about discussing the risk, benefits, and alternatives with the patient. Do you just document that, or do you have to put more? I've returned to your point and asked you to expand. It really depends on kind of what you're doing. What's the severity of it? How often do you do this thing? And sometimes you might want to give a lot more detail.
Right.
Like, what are you thinking?
Yeah, sure. If they're pregnant, I would definitely write a little bit more than I would for any kind of other thing. The other thing that goes with this is human beings are verbal and cooperative creatures, and so the very fact that you interacted with the patient and explained to them means a lot to them. I've rarely seen a case, in fact, in large databases that I've searched, whenever there's a well-documented risk and benefits conversation, I've never seen a successful claim in any of those.
Yeah.
Well-documented. Yeah.
So transitioning the conversation from informed consent, these separate written consents, consent documentation, to shared decision-making. I think these things are related, but they're a little different. So I know you're a big disciple of shared decision-making. I hear you say shared decision-making all the time. So how is that different than just informed consent in the informed consent conversation?
Well, that's very good. So shared decision-making, informed consent is when you think that a certain direction is definitely better than another direction. So say, you want to do a CT scan and there's some risk. There's some risk, but the risk of not doing the CT scan is greater. Shared decision-making is more when you have two options. Well, because you're not going to share in a decision that's bad, right? If it's good to do a CAT scan and bad not to do it, you're not going to say, well, we cannot do it in that shared decision-making. You don't share in bad decisions. Shared decision-making is where you have more or less equivalent risk. So say you do the heart score, heart pathway, and the risk of having a MACE in 6 weeks is about 1%. Well, the risk of hospitalization is also about 1%. So that's the time where you have the conversation with the patient. You say, here's the two options. The risk is close. This is a situation where where I can't tell you what the best is. I can just tell you that both of these are approximately the same. That's perfect for shared decision making because they get to choose what their options are. So they can choose the risk of going home, that's about 1%, or the risk of being hospitalized, which is about 1%. So that's the key to shared decision making. That's what you use whenever the options are about equal.
I take the question of, is writing risk benefits alternatives enough? And I think in some cases you want to put a little bit more detail depending on kind of what you're dealing with. But also then you can add in the shared decision making language and documentation after discussing the risk benefits alternatives, and the patient elects to do this. And we had a shared decision-making conversation around it, and I agree that's reasonable.
Yes. There's that kind of, yes. Anytime the patient says yes to what you say, you should write that down. Yes, that's a more regular sort of, I consent to what you're saying, shared decision-making versus the more sophisticated, we're in a kind of a gray zone here, shared decision-making, and both are very protective.
And you mentioned a CT of a pregnant patient.
Yeah.
Is that a potential case for shared decision-making or no?
Yes, I think that you could, if the risk is approximately equal. I mean, if the patient clearly, yeah, I would say yes. If the risk is high enough that you want to do a CT, but not so high they should go straight to the OR, or if the risk of going to the OR is greater than the risk of CT, then I think you would do it as document what you recommend and why. And if you clearly think it's more risky, okay, here's the beauty of it is, we have this great fear of delving into the language and consent and all that stuff, but realize this is your home turf. You control the dialogue. You completely control how things work, and this is actually you should feel that this is your strong point. So if you really feel like the risk of not doing a CT is greater than the risk of doing a CT, then just recommend that and have them agree. If you're not sure, if you're on the fence, then handle it that way. In other words, whatever you honestly feel, given your assessment, handle it as either they consent to what you recommend or you share the decision making with them if there's no clear alternative. Because remember, it's not you taking a risk with your health, it's them taking a risk with their health based on your recommendations.
Yeah, so kind of continue to extract from the question and say, now we're in this example of you're giving a CT scan to a pregnant patient. Okay, discuss risk benefits alternatives. And then the key phrase I'm kind of hearing from you is shared decision making is a good tool when both options are reasonable. The risk of both are roughly equal. So say we're in that situation, pregnant patient, CT, the risks are roughly equal. Discuss with the patient risk benefits alternatives. Potential risks include, the potential risks of a CT to a pregnant patient. You can list those out. Discussed the risk on both sides. Patient elects to proceed, and we discussed in a shared decision-making conversation. Patient elects to proceed with the CT. Now we're cooking. Now you've got the consent documentation, you've got the shared decision-making documentation, and the thing I like about shared decision-making documentation it's a description of the communication you have with the patient in which you both elected to proceed in a certain way that was not certain. There was acknowledgement of a risk in the avenue that you went down. So what that allows me to do, if something goes bad, I'm able to take that shared decision-making documentation and say, okay, so something did go bad. Well, let's continue the conversation. Let's keep, a positive dialogue with the patients when we're trying to keep a claim from happening, and describe what we can answer your questions, tell you what happened, and then talk about what we can do now. As opposed to if the documentation just says, well, and crudely stated, I'm the doctor and this is what we're going to do, and then it turns out to be, quote, wrong.
Right.
It's just, less defensible.
Yes, and also it's on the other end of that. It's not defensible to say patient declines. That means nothing. They could have declined because you went up to them and said, that CT is going to kill your baby. So, that's not really a consent conversation either.
Yeah.
So, to say declines, it's kind of like the alert noted times 4 for an appropriate neuro exam. It makes you feel good, but it's actually meaningless. You have to say that, say they decline admission or they decline a CT, the patient does not agree. If you share the decision, they said shared decision making, the patient would rather elects to go home rather than get the CT and will come back if the pain gets worse. Or if it's admission, the patient would rather take the risk of going home than the risk of being in the hospital, which are approximately equal. But say they don't want to do what you recommend, then you have to document that they declined, and that they declined understanding that the risk of what they're doing is higher. And I think we're going to get into that more, but to foreshadow that.
So that's shared decision making. That's something we like to talk about a lot because it really gives me a lot of value in defending the cases.
Huge. And think about it. How can someone sue you for a decision they were part of? It's kind of weird, isn't it? No.
We also get a lot of questions about A.P.P. supervision. It's a hot topic, been a hot topic, continues to be a hot topic. It's usually, the question is usually phrased in, terms of, I don't want to sign the charts, help me. Or, my site is starting to utilize more A.P.Ps, and maybe the physicians are kind of worried about it. Can you help me work through those issues with all the different team members? Well, it's a little bit more complicated than that. A.P.P. supervision is a complicated legal area. Every state has their own regulations around A.P.P. supervision. The hospital policies and procedures are often very different from the state's regulations. Maybe a lot of them go a lot more robust in their policies and procedures around A.P.P. supervision. The different payers have different requirements for A.P.P. supervision. So this is why this area gets kind of complicated. And so we see a lot of different ways of approaching the issue of A.P.P. supervision. Now, if we were able to design the perfect system, if it were up to me, it would look something like every A.P.P. has a delegated supervising physician. There's a committee of supervising physicians and A.P.Ps who review about 10% of the charts a month, and then they have some meetings to talk about performance improvement. Usually not how it works. So how do you see it working in some of the shops you work in, and what's your opinion? And what do you like
I
to
think
do?
the system you're proposing is excellent for reviewing, but the ideal thing is to leverage the strengths of the A.P.P. and the physician together. And so the risk of A.P.Ps and physicians is about the same. They miss slightly different things. And A.P.Ps have a harder time with really subtle cases where there's multiple little kind of things that don't quite fit together right. And physicians, we tend to take shortcuts and go around things like PERC rules and things like that. So if you put those two things together, you're really pretty bulletproof. So the key there is to communicate well. And when you look at risk across the landscape, where do A.P.Ps have risk? Well, they don't have risk based on the patients that they see. They have risk based on what is the setup in the ED they're functioning in. So if they're in an ED where they're separated by 20 miles, where there's unfriendly, where they can't communicate well, that's where the risk is going to be. And so it's a done deal that this is going to be a significant part of our emergency departments, no matter where we practice. And so you can take that and you can make it function well, or you can make it function poorly. I find them to be extremely valuable, and I think of it a little bit more like the way I think of it more the way I interact with residents, where we're all working together, and like a third-year resident, I feel comfortable with 99.5% of what that resident does. And so effective communication is the key. That's my soapbox. I think we didn't want to get so much into the soapbox, but that's the key.
No, I appreciate that. Because when we get a lot of these questions about A.P.P. supervision, and for some of the physicians in particular on the front lines who maybe think that, this is a change that they're not particularly comfortable with, the lines I've started to memorize are, okay, well, A.P.Ps are a fact of life. This is a team approach now. It is not just the physician who just kind of comes in on a magic carpet and says, you're sick and you're not, and they're the captain of the ship. It's a team approach now. The world has changed. The more you resist that, first of all, the more uncomfortable you're going to be because change is going to continue to happen. However, if you bring an attitude of negativity to it, if you approach the team approach of A.P.P. and physician as an unsafe situation, you're not comfortable with it, you don't like it, they're here to take our jobs, you are going to create the kind of non-collaborative environment that is a self-fulfilling prophecy that will make the situation dangerous. And I've seen it before, that these physicians kind of resist the team approach, creates a non-collaborative environment. If there's a bad outcome that happens, as they say, see, I told you A.P.Ps were dangerous. No, A.P.Ps aren't dangerous. It's all about the process. By that logic, physicians are dangerous. The ER is dangerous. It's all about having a good collaborative process between the physicians and the A.P.Ps. Now, I'll turn that around a little bit and not just come down on the physicians entirely. A.P.Ps as well. You are an advocate for the patient as well. And sometimes, you have to get over the hump as well and bridge the divide with the physicians who maybe they're not too sure about this, maybe this is new for them. Well, you need to say, hey, no, I really need you to see this patient. And if they say, no, don't worry about it, well, that's a problem. That's a problem maybe you can address in that instance, but also a problem you need to address globally with leadership to say, hey, this isn't quite working, and because patients will be harmed in that situation over time if you don't have a good collaborative environment when it comes to A.P.P. supervision.
That's really good, Dusty. I think, and pointing out, it takes a team. So, and you have to get used to the fact that if you're going to practice at the top of your license, then when I practice at the top of mine, sometimes I'm in situations where I need some help, and I'll reach out to a colleague or I'll call a system we call fail-safe. And if this collaborative approach, you will have to get used to the fact that sometimes what you think is going to be incorrect. But the benefit of that is that you're working in a team. You're going to miss much fewer stuff. And actually, the relationship between doctors and A.P.Ps is not actually additive. It's actually synergistic, because you stack us right. We're not going to, between us, our different skill sets are going to make sure we don't miss, we miss almost nothing, which is pretty amazing.
And tomorrow I'll talk about some documentation tips for A.P.Ps and physicians and what to document when you collaborate. Now we'll get into a more kind of legal issue, duties to third parties. This comes up from time to time. You see somebody driving off drunk, or maybe they come in, they've had a seizure, work them up, discharge with his wife. A month later, they're driving, seizes again, severely injures somebody. You sue the physician. Is the physician liable in that situation? We've been through this so many times. I'll ask you, counselor, is the physician liable in that situation a month later?
Well, yeah. I mean, I've learned this from you, Dusty. But essentially, unless there's a specific person that's going to be harmed, you can't protect the entire world from someone, from someone who's going to have a seizure.
Yeah.
But say someone is, so you can't protect the entire world. So there's a duty to inform when there's a specific person who might be harmed.
Yeah.
And there's a famous case that I think you're going to refer to, the California case.
Yeah.
So.
And when it's a specific person, the key is foreseeability. Foreseeability is a very important term in the law, because as a society, we don't hold each other accountable, that is liable, for harm to each other unless the harm was foreseeable. Otherwise, how can we improve our behavior if we're liable we hurt people who we had no idea would have been hurt? And there was a case called the Tarasoff case in California, in which a young man was at a psychiatric hospital talking to his therapist and said, yeah, there's this girl, Tarasoff, and I'm in love with her, and as soon as y'all let me out, I'm going to kill her. And they at that time, there was no ability for them to warn that girl without breaking confidentiality. So they didn't, and he killed her. And they, the family sued the California Board of Regents. You know, it was a state hospital, and they won. And in that case, the California Supreme Court said because of the very clear foreseeability in the identity of the victim, these medical professionals had a duty to warn. They had a duty to do something to prevent this foreseeable tragedy from taking place. Now, and that does vary from state to state. In Texas, where you're from, John, you know you can't warn the victim, but you can call the police. I believe, right. And you can only call the police, correct?
That's right.
Yeah. So it varies a bit. But if you're dealing with somebody who says, you know what, I just can't take it anymore. I've had it with Trump, and I'm just going to go, I'm going to go cause some havoc. Okay. You might want to think about talking to this person. Maybe they're unstable. Maybe there's a hold that can be considered. But there's no foreseeable target. But if somebody says, I've had it with those hippies down on Congress Avenue Bridge, and later today I'm gonna go take them out. Okay, now you've got a foreseeable victim. There's something you should do there. And in Texas, you would call the police.
That's right. And also, just there's gray area zones where you're not sure if you can, well, actually, we'll get into psych stuff later. Never mind. We'll cover that later. We'll get
into it now.
Yeah.
So foreseeability is pretty easy when you're talking about murder. Another one before we get into this one. What if you got a drunk? A drunk person?
Yeah.
And you can't hold them, let them go, and they hop in their car and they drive away.
Okay.
And you notify anybody without?
Yeah, so that's a really good one. So if you're evaluating someone and you're sure you can take away their civil liberties, do it. If you're not sure, don't do it. But if it's a gray area and they leave, then you just call the police and have the police bring them back to continue the evaluation. The specific case, if a drunk person leaves your ED and he's not so incapacitated that you can't hold him, well, he can just tip out the door. But if you see him get into a car, then you call, but not because it's a medical thing, but because he's violating the law. And so you call for a violation of the law. So that's how you can call the police for that.
Right. In that situation, you're acting not in violation of HIPAA as a medical provider. You're acting as a bystander. You're saying, hey, police, I saw this drunk guy get in a car. Now, if you say, and he's got this STD I'm going to tell you about as well because it's a doozy, that's a problem. Now you're getting into HIPAA violations. But just the facts of, I saw a crime being committed, that's not a HIPAA violation. It's not medically protected.
Yeah.
Now, speaking of, so when it comes to foreseeability, when it comes to third parties, what about sexually transmitted diseases, that sort of stuff. The guy coming in with genital herpes. Girlfriend says a year later, now I got it, you should have told me, you're liable here. Now, kind of just going through the exercise. Okay, was this a foreseeable victim? It looks like you didn't even know she existed at the time.
Right.
Yeah. So without it being a foreseeable victim, there's no way a physician could be or a clinician could be held liable in this situation. There's a good traditional rule in medical malpractice law that there is no potential liability until there's a duty created by the physician-patient relationship. Traditionally, the physician-patient relationship is created when you physically touch a patient. That's been evolved a bit, by kind of the changing nature of medicine, with telemedicine, with phone calls, with on-call physicians. But still, that is a premise we can bring up in malpractice cases. So in this case, no physician-patient relationship. You never even saw this person. Now, that doesn't mean you should not do anything at all when this gentleman comes in. I imagine you would, this might be a reportable condition to the county health department.
Correct. So, disease, there's a set of reportable disease, and it doesn't have to be an STD, of course. It can be tuberculosis, diphtheria, a variety of ones. So these are public health concerns. They're just not concerns related to a specific person that you can identify. So you notify the health department when it's and in some jurisdictions, and it varies state by state, county by county, it may be a reportable disease, it may not.
Mm-hmm. And I like the risk mitigation tool of counseling them on informing their partners. Is that something you just hand them, or do you talk to them, or kind of what do you do?
Yeah, so I work in a hospital that uses a system called Meditech that hands people basically a book about that thick for a sore throat. So I think that that's not meaningful. I think when again, I said human beings, we are cooperative verbal creatures, and so when talking to someone, no matter how brief, is better than just throwing a bunch of instructions on them. So.
All right. Difficult patients is kind of a catch-all, kind of incendiary word to me for basically just patients who don't want to do what you want them to do. And there's a wide spectrum of these patients. And here's a good example. Fellow comes in for chest pain, acute MI and ECG, wants to go home, despite your adamant recommendation that he be admitted. So you've got an AMA situation here, just full-on AMA. Now, and let's talk about first the difference between informed refusal and AMA. Now, AMA, you want them to be hospitalized, and they say, no, I am leaving. As opposed to informed refusal, kind of what's the difference there?
Yeah, that's a really good question. So in a certain sense, they don't really matter because they're both a matter of informed refusal. But just for purposes of your hospital and quality and a variety of tracking things, AMA is considered different and is considered more negative to your hospital and to your contract. So it doesn't really matter in terms of the legal part of it whether you sign someone out against medical when you have a refusal of care versus against medical advice. But you only want to use against medical advice when it involves hospitalization, just for purposes of tracking to your hospital. But generally speaking, the key to these is, so in other words, AMA is just a subset of refusal of care that involves hospitalization. To limit your liability, what you have to do is show that the patient is capable of understanding the risk, that they're fundamentally capable of understanding, and that they understand those specific risks associated with what they're doing, and versus the benefits of what you're offering, and then that you gave them some alternatives. So they refuse to be admitted. Okay, you refuse to be admitted. Well, I did a mental status exam, and you're capable of understanding that there's a small chance of dying from this MI. The second thing is that you understand that, and that you understand that I'm offering you something that's going to mitigate that. The third part is you offer an alternative. Okay, you don't want to be admitted. Will you at least take an aspirin and see a cardiologist? And here's the name of a cardiologist that you can see in 24 hours, or you can come back. And then you document that you did all of that. Mm-hmm. And so I think that you have to sign an AMA. Again, we get all worried about this, but just remember, this is your home turf. The chart is your home turf. And you can't control anything in this world, but you can control how good the chart looks. So you write all that down. I personally don't sign it unless the hospital requires that I sign an AMA form.
Yeah, AMA forms get a lot of questions about those, and I think there's a popular misconception that AMA forms are a get out of jail free card. Like there's this what's that thing I said, like the AMA fairy. You take the AMA form and you put it under your pillow and you expect to get $1, but really, the AMA fairy takes your wallet. Because if you put all of your eggs in the basket of the AMA form, you're going to miss out on a lot of good strategies to mitigate your risk in a situation like we're talking about where they say, nope, I am leaving. There's a good example that you had in Texas, and it was the same case of the MI. He was an older gentleman, though. He was a rough old bird from up northwest of Austin, and they said, dude, you're having a heart attack. You need to come in. And he just said, nope, you know what? Pass. I've had enough. I've had a good life, and I'm out of here. And the doctor's like, dude, you're going to die, if you don't come in. And so it brought in all of these strategies. And I was proud as they did it even before they called me. So they called another physician. All the nurses come in there and talk to this fella. They get the family members in the room. They say, who are the other family members, the immediate family members we need to talk to? They get them on the phone. They're documenting all this stuff. They call hospital risk management. They're savvy to the situation. They come down. They break out their forms. And then after all is said and done, I kind of think you got to have a little respect for this fella. But he just walks out the front door hand in hand with his daughter, and I like to think he was wearing a cowboy hat and like a tumbleweed was going by and the sun's going down because he just walked out, you know, to his death and did it with his boots on. Now, that's patient autonomy, you know, but to protect yourself, especially from the son who wasn't there, what you're going to do, you're going to use all those strategies in a difficult AMA situation like that.
Yeah, you're right, Dustin. And anytime I've had someone that is refusing something that really doesn't make any sense, I bring their family in, and 99 times out of 100, once the family's in, my job is done. They convince the patient, and I don't have to spend an hour doing it.
Yeah.
So. But if the family agrees, then that's definitely the right thing. Was there a question?
Yeah.
What about a patient that are
Well, definitely, yeah.
not, I mean, that are not
Yeah.
the best choice?
Yeah, so the question...
Yeah, go ahead.
Say somebody with something happens, you know.
Well...
A documentation thing, do you let them
Yes.
do that?
Yes, so the 2 points are, would you offer an alternative? The answer to that is yes, offer them the next best alternative. So if they don't want to be admitted to have their appendix out, then you know what? The Finnish study showed that maybe some people do okay, send them out on antibiotics, bring them back in 24 hours for a recheck and a rescan. That's not ideal, but that would be reasonable. The second part is, do you document? So it depends on, so as I've gotten wiser and I've practiced longer, I've realized that, again, I'm going to say this one more time, this is my home turf. I practice with amazing clinicians like Dr. Baugh back there and Tiffany Bogus, A.P.P. And they're amazing, and I'm pretty good, but I'm certainly not as fast as they are, but I've never had any problem. And it's because the chart is my home turf. I control it. I control how it looks. I write good narratives. And it also comes from the heart, and it expresses what I really think. So I think if you feel self-assured, and you feel confident, and you feel like you're golden, don't sign it. Just write what you did. If you want to get extra coverage, then go ahead. It depends on how you feel about it.
So what would you write if you are okay with that?
Oh, yeah.
That lesser
that's
treatment?
right. So the 3 simple ones: the patient understands, he's capable, he knows that according to my recommendations, that what he's doing is more risky than what I recommend. I offered him this alternative, and he is going to come back. He will follow this, and he'll come back in 24 hours. I give him some reasonable thing. Yeah.
What do you do with the patient that just up and like that's it? Leads are coming off. I'm walking.
Oh, that's very
Screw
good.
you guys. What do you do with the patient who says, "Screw you guys, I'm going home"? Okay.
That's a good one.
Okay.
You want to take it? Okay.
I want you to take
Okay.
that one.
I love this one. Okay, because this one, what I write is the patient unilaterally severed the doctor-patient relationship. And so in other words, you don't say, I let him go, I did this, I did that, severed the I did not, and you write, he unilaterally severed the doctor-patient relationship. I did not have the ability, I do not feel like I have the ability to physically restrain him and take away his civil liberty.
Yeah.
So in other words, if someone does that, and they're high and they're crazy, okay, no, you still have to, you don't have to, but someone's got to try to tackle the guy, okay? Bring him, keep him. But if he's not, let him tip out the door. You cannot take away his civil liberty. We will always, no matter what Bernie Sanders say, always be a center-right country. Always have been, always will be. Center-right. And so civil liberty is if there's anything such as a magic bullet that you can put in your chart, say, I do not have the ability to take away his civil liberty guaranteed by the Constitution. Constitution in there.
So like a true Texan.
Yeah. And so that's one part. And so then, you don't restrain him, you don't tackle him.
I would add, and we'll talk about this a little bit in the documentation lecture tomorrow, but objectively describe what happened. Patient left, severed the physician, but if they literally ripped them off, describe that. And if they, threw a few choice words at you on their way out the door, which they probably did, go ahead and write them down and just objectively describe what happened.
Yeah. And on the back end, call the guy the next day, or have someone call him and say, we'll call him, we'll see how he's doing. Because if you can always, no matter what happens, if you show that you're kind of the white knight or the white hat in the Western, you'll be fine.
We're gonna keep cranking, and we'll have time, and we'll end a little early. But I definitely want to have time for.
And we have one question there when we're.
Well, let's keep.
We'll grab it at the end.
Let's transition from. So you're talking about your interaction with patients, interactions with other physicians. I definitely want to get the benefit of your experience, because what I see a lot of times is younger physicians getting bulldozed by older, crankier physicians who have a lot of political clout. And I think if they were talking to you, it wouldn't have gone that way, and we wouldn't have had this bad outcome. So like the situation. you know, you want to admit somebody and say, I'll see him in the office tomorrow. So tell me about your strategies for taking care of the patient, getting what you know needs to be done when that consulting physician says, give him 2 aspirin and I'll see him on Monday.
Yes, that's so first off, even before you make the call, you have to decide in your own mind what you want from that consultant. And you have to decide, do I want this consultant to do something? Or do I not want them to, or more simply, what answer do I want for them consult? Is there something I want them to do, or am I not sure what to do? Or is there something in other words, do I want them to see the patient? Do I want them to not see the patient, or am I not sure? So in other words, you decide which one of those beforehand, because if you don't decide beforehand, then the conversation, you're behind the 8 ball in the conversation. So when you talk to a cardiologist that you want to admit a patient, then you say, I need you to see this patient, or I need to admit this patient. And then it's now theirs to show you that they don't. Whereas if you start off without that, they don't know what they're going to try to get to what's ever easiest for them. So first of all, decide what you want. Now, say in this situation they're not telling you what you want. Well, the first step is to say, what is the evidence? So if this person has a high heart score, then you say, I really can't do that. I can't send him to the office. His heart score is too high. So that's the first thing you do to convince them to do what you think. So start with data, and then a stepwise approach. If that doesn't work, then you, if data doesn't work, then you may have to say that you can come in and discharge the patient, but I'm not going to send him home. If that doesn't work, then you say, look, this is kind of how it works. EMTALA says that if I call you and you see a patient, you have to see him. I hate to pull that trigger. I hate to get all official and on you, but if you don't, that's going to be a problem. So I've handled surgeons like that when they don't want to come in and operate on something. So that works very well. So you escalate. So first start with evidence, start with a little more persuasion. They can come and discharge the patient, and if not, just say you're going to, that they have to come see the patient and discharge them. But again, that works. You don't want to do that whenever you're equivocal. So if you've already decided, I'm not sure what to do, I want the cardiologist's opinion, then fine. You've already started that. You've already set the preconditions in your own mind so that whatever they tell you, you're comfortable with.
Yeah. And I'll talk a little bit about at the EMTALA lecture tomorrow how to use EMTALA like a tool like that, with creating this conversation with the consultant saying, look, it's not up to me. I didn't create this situation. But if you don't come in and I have to transfer the patient, I have to document your refusal. And that'll be a real problem for them. They will get so mad. But
yeah.
But as long as and John Casey will have some other advice on that as well. So, but I like that, the stepwise progression and just creating the narrative of, look, if you don't come in, this is what I have to do. I'm sorry.
Yeah.
That is what it is.
Yeah, and there's also, of course, I forgot to mention, there's peer review in there, hospital peer review.
Yeah.
Where if I send this patient home, you and I are both going to get put them together. You and I are both going to get barbecued if we send this patient out.
Yeah. And so, in transitioning to, so you're dealing with the physicians up on the floor. So you got fever, cough, shortness of breath, dizziness, chest X-ray shows what it shows, treating for pneumonia, antibiotics. So you take care of the patient, but you send them up to the ICU and says, I'm going to see him soon. I can't come in now. Write me some orders, please. And then the patient codes 4 hours later before the primary care physician is there, and you are allegedly held liable for that case. So, and this is a common question, when you're dealing with admitted patients, writing orders for admitted patients, that's what it's all about. Is there any specific do's and don'ts you see? I mean, do you refuse? Would you refuse in that situation to write an order on that patient, or what would you do?
I never refuse to write orders, admission orders on a patient, and here's why. There is some risk of admitting a patient, of writing orders, but it's much less than the risk of ED crowding. So every hour practically that an admitted patient is in the ED is increased risk. So I always write the order. But again, decide beforehand, okay, I'm going to write these orders. How long do I expect this patient to be stable? So write the orders and put a time limit on them to say that these orders are good until a certain amount of time, and thereafter renew only if approved by Dr. So-and-so. So that's kind of how I write it. And I'm willing to write admission orders to the ICU. I'll just make it like 2 or 3 hours or 4 hours. And so with higher acuity, they're shorter orders. But getting that patient out of your ED and in a place where they can have some one-to-one nursing or one-to-two nursing even, that's huge. And it also, I kind of, from the intellectual point of view, I really kind of like delving into that and understanding a little bit of how things work in the hospital, because we think about our own risk only, but patients experience risk in the transitions, and the smoother you can make that transition, the better.
Yeah. So some good mitigation tools for this common issue of writing orders on admitted patients. Another thing that comes up from time to time is you've got private patients in the ED. Somebody who's sitting there waiting on, in this case, they're gastroenterologists. It's all in the office, and they were advised to meet the GI doc in the ED for evaluation and admission. 2 hours later, things go south. So it's just kind of the general question of, I mean, does this come up in the ED of private patients sitting around waiting for somebody other than you?
It comes up fairly rarely, and you know, the issue is that if something happens while you're there, then you are sort of responsible, or someone's going to end up being responsible, so you don't want that. Now, that being said, if a private patient and a doctor have made an arrangement for them to meet in the ED, then I respect that, but I'm also just going to at least come in and say hi and acknowledge that and say, hey, if you need anything, and that gives me a chance to eyeball them, make sure they're stable. And if they look bad, then I'm actually going to say, if something that looks bad about them, then I might say, is it okay if I order some labs, okay if I get an exam, okay if I do things to help. And then I might call the doctor and say, your patient looks really bad and get here sooner. So again, it's one of those things where it's going to happen from time to time, and you can either make it negative by either ignoring the patient entirely or by going there and getting all pissy with them, or you can make it cooperative and help the patient and your ED.
Yeah, that situation borders patients who are in your ER but technically not in your ER as an ER patient. Maybe they're an admitted boarder. So yeah, you have lower responsibility to those patients, but if that patient has a bad outcome in your ER, it's still your ER and you're somewhat responsible. You know, if not from a legal sense, then from, you know, what's right for the patient.
Well, you're going to get named. And just being named is misery.
Yeah.
Misery. Yeah.
Okay, so let's talk about house staff, folks who are in the hospital. So you got someone with acute abdominal pain. They come in, they evaluate the patient, discharge the patient after presenting the case to the attending by telephone, returns 2 days later via EMS with a ruptured appendicitis. Now, I see cases like this. Mm-hmm. So, I mean, just generally, you know, are we talking about a resident here or
Yeah, the issue here is when the residents discharge someone without their attending seeing the patient, and this is a little bit of a gray area.
Yeah, so if you're in this situation, that resident's going to discharge the patient. I mean, do you say to yourself, oh, well, good, they know a lot more than me, I'm going to be very comfortable with that, or what are your feelings on that situation?
So again, I've decided beforehand, do I want the residents to take this patient to surgery? Do I want them to let the patient go home, in which case I'm probably not home anyway, or am I not sure and I'd like someone a second opinion. So if I've decided that that patient needs surgery, well, that patient's going to get surgery one way or the other. I'll make sure it happens. But if it's in the gray area, then I've already decided, they've already said, we think this patient's okay, and I can go with that. And again, that is a situation where the risk is lower or at least the same as you having seen the patient and decided that, you know, they probably don't have appendicitis.
Yeah.
Now, go ahead.
Well, in the cases I've seen, it's a resident or maybe like the surgeon's PA comes down, and our provider never even really knows the details of who came down. Yeah. And then they find out 6 months later when they get sued. Yeah. So it's just that kind of that absolvement of from the situation. Because that resident, somebody from the specialist is involved, that I think you have to fight against. So try to stay involved in some sense to make sure.
Oh, definitely, yes. If you think the patient needed to go to surgery, don't let that patient not get surgery. So if a PA or a resident's come and see the patient discharged, and then you have to talk to the attending, and it's usually very collegial and just say, hey, listen, you know, I think that this risk is, it helps if you do something like an appendicitis score or something like that. It helps. And of course, if that's the case, then you can, if you don't have a CT, you can get a CT, which is about 94% sensitive. So there's a lot of different ways to work it. But yes, absolutely. Unless, if you think someone's got appendicitis, unless someone comes in and discharges that patient, don't give up on that and just continue to work it. But don't go straight to the, I'm going to report you to the medical board. You just have to go step by step by step. Unfortunately, these cases are rare.
Yeah. Similar advice on those psych teams. You know, some facilities have stronger psych teams than others. Some places, like California, you're actually immune from liability. You can legally rely on the assessment of a psych team. But again, kind of a similar, I think, general vibe of, yeah, you can rely if you agree. And in this situation, you got the teenager, you know, relevant to what Nate was talking about, suicidal ideation. They come in, they assess patient, discharge them, 12 hours later, she's dead by suicide. So is the ER physician liable? Yeah, it depends on the state, depends on kind of a lot of the nuance of the facts. But if it was unreasonable to rely on their assessment for an ER physician, of course the ER physician can be held liable. It's really your ultimate responsibility to discharge the patient. Now you can, you know, certainly rely, but again, if you agree.
Yeah, yeah. And again, you'd have to decide beforehand. Do I feel comfortable with whatever they say? Do I want them to do it this way? And whichever one of those decide, then that's what happens afterwards. And if you feel comfortable with what they say, then let them discharge them by all means.
Yeah. Another question that we'll get from time to time are in-house emergencies. Hey, John, I work at a small site, and they expect me to respond to codes upstairs, and sometimes I'm the only ER provider there. Often it's presented as make them stop, to which we say, well, who else is going to do it? But what are some things you can do to limit your liability in those situations? Well, I'd say one, stop resisting. You know, stop trying to fight a battle you can't win. But in those situations, I mean, you have to make a judgment call. If there is an emergency on the floor you have to respond to, assess the safety of leaving the ED at that moment.
Yeah. Yeah. So the thing you can do to make sure that your responses are as effective as possible is, of course, have a glide scope and a airway kit, because that's the most common bad things that happen. But as far as that goes, say, for example, it's not an emergent code. Say it's just someone who needs to be who is tachycardic or somewhat unstable. Then I think that if you can leave the ER safely, then leave the ER safely. If you can't leave the ER safely, then talk to the house supervisor and work something out. I actually was once in the hospital where I had an incredibly unstable patient in the ED waiting transfer and another patient upstairs, and it was a very small hospital. I said, well, look, just bring him down and we'll treat this, and can we make this bed number one an ICU bed, and I'll bag both of them. In other words, the key to these very rare situations is to use the resources that are available. But generally speaking, you can't fight your legal obligation or your contractual obligation, and you certainly don't want to be the guy that loses the contract for your group because you failed. You just didn't want to go see a patient upstairs.
Yeah. So DNRs, they come up from time to time. Say we got a situation, someone who's dying. They come in. You don't have the advanced directive documentation. Family's not there. They're going under. Do you initiate resuscitation?
If you're not sure, let me see, sorry, just a minute. No, yeah, yes.
Yeah.
If there are no advanced directives, and I know from experience, if there are no advanced directives, save the person's life first. The first prudential rule of medicine, first save their life and then deal with it. I have even resuscitated and intubated someone. Actually, I even criked someone who was DNR because they had no paperwork. So, and was I sued? No. Did the patient even complain? No, they didn't complain. So, first save their life, worry about the rest later. I mean, even there's a famous case of the guy who had his DNR tattooed on his chest. Well, that could have been his initials. Who knows? A tattoo does not count as an out-of-hospital DNR. So
an advanced directive is what you're looking for. However, how often do they show up with their advance directive laminated that they hand over to you. And it should name a surrogate for their power of attorney for healthcare. That's who you're looking for. Did you have an addition to that?
Nope, no, there was nobody in this time. But again, yeah, unless you're absolutely sure. So what if you intubate someone? You can always take the tube out if the family comes on and says, I didn't want it.
Yeah.
Has there ever been a successful lawsuit for saving someone's life, Dusty?
No, there's been complaints, but no real liability. I mean, that is not to say, and I like to make the point, I mean, you do not have to provide futile care. The clinician's judgment is important in these situations. However, when you're in that gray zone, you could go one way or the other. What's the right thing to do? Yeah, you can't take back the decision not to resuscitate. Yep. And particularly in some states like Texas, we've passed pretty serious laws about, right to life, resuscitation, all that stuff. It's kind of a sticky area, so when you're in the difficult zone, you don't have to provide futile care. Your clinical judgment is important, but on balance, probably better to just go ahead and resuscitate. Yeah. Radiology discrepancies, I know Ross has talked about, it bears beating the dead horse because discrepancy cases still happen. Discrepancy cases are killers. They sink groups, they sink careers. They are very understandable by juries. I certainly understand. Wait, there was something on the x-ray and nobody told them, and 3 years later they're dead of, turbo cancer. That's terrible. We should give them a lot of money. So these cases still come up. It's very frustrating. There's no excuse for not having a policy to prevent a typical case like this of, they get the read back, and it's faxed, of course, because it's some old crummy system, and later on, they die of cancer, and something could have been done. There is just no excuse not to have a good process. And it has to be a proactive process set up by the facility. If there isn't one, own it. Exert yourself and take the leadership to try to put one together. We were sitting back there talking and saying, well, what are some risk mitigation tools if, you're not attacking the problem of the process? What can you do? Well, I guess you could warn everybody that their x-ray might have cancer. You can't really do that. But maybe if there's a overread system, you were saying, like a Nighthawk system, maybe you do something around that. Yeah,
if you're discharging them, say you have a place where I work in some sites, I like to work in all sorts of sites, but where certain on weekends, x-rays don't get read until the next day. Well, then that's the one where I will tell people that sometimes the x-ray looks normal to me. Sometimes that will change. If we find something different, we will let you know. So that's 5 seconds, pretty quick. The other thing is if there's a Nighthawk, and that's slightly dangerous. In my opinion, what's even more dangerous is when there's 2 radiologists reading, because then you get a semi-conclusive reading and you think everything's okay, but the next day someone might overread it. So if you work in a place where things like that are read, for sure, give them a warning about those types of findings. The other thing you can do is, if possible, so radiologists are supposed to put what's really the most important first, but they don't always do that. But whenever you can, if you have the time, make sure you read everything, because sometimes they do bury the significant findings in there. So try to read whenever you can, and it's not possible. It really is not possible, but try to read all the report. But famously, especially CAT scans tend to have very complex readings. And that's where you'll find there's a nodule here or a nodule there or hemangioma here, hemangioma there. So CAT scans of the abdomen, try to read those, try to read the whole thing.
Yeah. There's been a number of cases, John and I sitting around reviewing a case, as well as another physician we work with. And the other one, particularly Sam, will get very frustrated. Just like, darn it, these radiologists always burying the lead in the most important information right here. To which I say, well, they did. Okay, that's what they do, and we don't control them. So you could try, but what are we going to do about it in the things we can control? And really, in that situation, I think all you can do is just be savvy to those risky presentations, imaging, and look for the serious stuff that they very well may have buried in the bottom.
Yeah,
of
and
the
make
fine
sure that
print.
your system, your EHR, has some kind of instructions about follow-up for nodules, because it's almost always repeat CT in 6 months.
Okay. Well, let's talk about consent.
Okay.
Then let's replace those last couple things with that other big legal issue we were talking about, and maybe we'll take a question and shut it down.
Yeah. Okay.
Handoffs still come up. I feel like providers are getting better at this, but we recently had a case just like this one. You got known pneumonia, returns to the ED with increasing pain, shortness of breath, evaluated by one emergency provider, decided it's safe to discharge before results of chest x-ray, CBC, signs out to a colleague. And you've got the results coming back, complains of worsening pain. First physician leaves after creating a complete note, assumes everything's in order, we're discharging this patient. Second physician says, oh, great, discharge the patient despite those worsening signs and symptoms, doesn't see the additional information. They return the next day, severe pneumonia, lung abscess, sepsis. We've seen a case like this. This still happens. So what's one thing you do to prevent that case from happening to you? Do you regularly sign out patients?
Well, yes, and the takeaway lesson is not don't do sign-outs, because actually there are a lot, sign-outs are by definition dangerous cases, and the fact that this is rare is very good, which means we're doing sign-outs pretty well. So I do sign out patients because otherwise you have to go home. You just have to get yourself home and get some rest. But of course, obviously, I go say hi to the patient, and I at least give them the eyeball look in the room. How do they look? And if they look great, if they're sitting there reading a book, they look great. I don't do a lot more other than just review their vital signs and look at the labs and look at all the stuff that might have come back in the meantime, and then that's it. How much I intervene depends on what my clinical impression is. So if they don't look good, then of course I'm going to do a lot more. But at the very least, eyeball them, review the vitals, and review the labs. So basically do a discharge time. What kind of a discharge timeout? So that's what I do. Yeah.
So with that, I'm going to actually skip, and I'm going to cover one more kind of last-minute point. So the topic of this lecture is top 10 legal issues, or prominent legal issues. Well, to me, if you want to know what the most prominent legal issue is in emergency medicine, it is federal surprise billing legislation. This is not a political statement, but this is something that you all need to know about, because we're talking about risk to your career, to your practice, to quality care of patients. I got to mention what's going on at the federal level when it comes to surprise billing legislation. We'll call it surprise billing. That's the term of art being used. Quick background. I imagine most of you know what balance billing is, what surprise billing is. If somebody goes to a hospital and the ER provider is not contracted with that person's payer for any number of reasons, the payer will pay their usual and customary amount. It is not enough. The patient gets a surprise balance bill. Of course, nobody likes it. Everybody would like to solve that problem, but the problem is, how do you solve the problem without creating a lot of unintended consequences? There are bills running through Congress right now, one in the Senate and one in the House, in which the solution is outlaw balance billing. Okay, sounds good. Nobody likes that. But what do you do in a situation where somebody sees an ER provider who's not in their plan? What happens? Well, what is in the bill is that there is a rate that is set. It is a usual and customary average rate, the median rate, depending on the bill. That insurance carrier has to pay that median rate to the provider, and then we're done. The outgrowth of that could be, and we are starting to see, even though these bills haven't even passed yet, insurance carriers will with their own power, terminate the contracts of folks who get paid pretty good rates and lower that median rate with the power that they have. So you are going to have a situation in which the insurance carriers start to kick people off the plans, kick emergency providers off the plans, radiologists, pathologists, and you have more out-of-network situations because they have the right to just pay their median rate and be done with it. So it impacts the folks who aren't contracted with insurance carriers, and it impacts the ones who are. The ER providers that are contracted with insurance carriers, because they just lost all their leverage to create good, sustainable contracts with the insurance carriers. And those quality groups can get forced out over time if this passes. It is a serious, serious threat to the practice of quality emergency medicine. So the ask of you is to go check out ACEP surprise billing. See what's on there. There are things you can do. Your voice really matters on this issue. I've gone and talked to the legislators in Georgia. I mean, you're part of the efforts in Texas. They listen to clinicians on this issue, and what can come out of this could be a good bill if a lot of people like you stand up and try to make an effort to improve what they're trying to do on surprise billing legislation.
Yeah, I mean, I'm a risk guy. I deal with rare and catastrophic situations, and even the worst malpractice crisis of the 80s and 90s doesn't bother me anything compared to this. This is truly an existential threat, and you got to call your senators, call your representatives, and I give a certain amount every month, and I just recently gave a big lump sum. This is a good investment in your future. What they're basically trying to do is leverage the history of the United States since about 1976 is the large financial companies, and make no mistake, insurance companies are not care companies, they're financial companies. They've been rolling the government ever since the late 1970s, and so don't let them do it to you. They want to cut your reimbursement by 50% or at least 30%, and drastically impact the way you take care of your patients.
Yeah, and bringing it back to what this seminar is all about, providing the best care, preventing bad outcomes, I am convinced that if this legislation passes, quality groups will have a much harder time taking good care of patients. And people are going to get hurt, and that's why I feel very passionate about this issue. But on that issue, we're returning back to the important legal questions. One question from the audience for the good of the order, and then we'll hang out if you have additional questions. One question. Yes, sir.
Yeah. So if
you want to involve the family in the AMA situation, but you're concerned about HIPAA.
Oh yeah. Well, if it's okay. So again, I go back to this, and it's my home turf. I'm going to contact the family because I think there's a threat to the patient, and the family needs to know. In other words, I'm doing it just like if I have an unconscious patient, an unconscious, found down patient, I rifle through their wallet like it's mine, not because I care what's in their wallet. It can be fascinating, but it's because I need to know. Where does this guy live? What does he look like? What does his skin color normally look like on the ID? So if you need to know, and the family needs to know, if you're doing it for the right reason, then just document. That's why you contacted it.
Yeah. Three points I'd make in that situation. I mean, one overarching point is in those difficult gray zones, what's right for the patient. And you know what's right for the patient. And what's right for the patient is to make the call. Now, when you make those calls, you can be diligent in what you say. The fact that they're there, that technically is, medically protected information. But, you can reveal a little bit of that. You can reveal a little bit about their concern. You can kind of gauge if they know what's going on. And then, if they say, no, we want to come down there, then you say, hey, can you wait a second? I called your wife, she's coming down here. The third point I'll make is, okay, in a situation of AMA, what are we worried about? We're worried about death. We're worried about significant mortality. In those situations, the wife is the one who will have the cause of action. So really, in that situation, the potential plaintiff is the person you're thinking about calling. So, maybe you get a bit of a HIPAA complaint from that fella. Maybe it just he gives it in your ear until the wife shows up, and then it's all over. But yeah, there's plenty of situations where you're damned if you do and you're damned if you don't. In those situations, what's best for the patient, which also happens to be the best risk mitigating tool, because realizing the person who might sue you is the person you might call. So I don't get too worried about HIPAA stuff. I'm not a compliance guy, but I have been, and HIPAA complaints really never caused me a lot of trouble, especially when the doctor's heart was in the right place.